AmCare 33, please respond to the hockey arena for a unknown injury involving a Zamboni. Copy, Central. AmCare 33 is en route.
Let's hit it. You got a pulse? Negative.
No.
Go ahead and shock. I got nothing. Shock again. Nothing. I got an idea.
Extreme measures.
Just might work.
Pizza. Welcome to another episode of Travels with Charlie, Vermont politics in real life. Wow, pizza! Today we're going to be talking about the cost of healthcare in Vermont, healthcare reform. We're at Northwest Medical Center in St. Albans. My guest for today from the Green Mountain Care Board, Tom Pelham. He worked in multiple administrations. You also helped restructure Vermont's Medicaid premium and copay system to better align with people's incomes and ability to pay. So that's going to come very helpful
far
today.
Away. You're making me feel old.
From Northwestern Medical Center, CFO Robin Alvis. Robin recently came to Northwestern Medical Center from Alabama. You'll get that in a moment when you hear her. Over 20 years of progressive financial planning in the healthcare industry. Robin, welcome to Vermont. And Tom, thank you for joining us as well today.
Glad to be here.
Good to see you again. How you liking Vermont, Robin?
I love it. It's not that far from what I'm used to. Maybe 50 degrees difference. But
Yeah. Let's move into the area of cost shift. Now, cost shift, and I'll try to explain it, and you can jump in and probably explain a lot better than I do. When Medicaid and Medicare do not cover the cost of service, non-governmental consumers then pay the difference. So Robin, let me ask you the first question today, bringing us to the whole issue of payer mix. The ratio of Medicaid and Medicare to private insurance, hospitals that have higher numbers of Medicare and Medicaid are at a disadvantage, obviously. How can that playing field be leveled?
that's a great question. Certainly here at NMC, we're a Medicare dependent hospital. And so what that means in a state like Vermont where our rates are regulated, a dollar rate increase for me with a much higher proportionate share of Medicare and Medicaid doesn't mean as much in terms of revenue generation as it would to UVM or any other hospital that had a much lower ratio of government payers.
No, you can look at the statistics, and clearly hospitals that have a high Medicaid population are more prone to have even negative operating margins because they can't cost shift onto the commercial payer. I mean, UVM's payer mix is up around 60% commercial and only around 10% Medicaid. So if they're losing money on Medicaid, which they are, and maybe even on Medicare, they can cost shift that in their negotiations with the private insurers because they have a large commercial insurance base. A place like here at Northwestern, or in the worst case, Springfield. I mean, Springfield had the worst case mix, payer mix of any hospital in the state, and you can see what happened down there. They're still in bankruptcy. You know, this is also totally unfolding in the context of these statistics, which the United States has the highest cost per capita of any country in the world, any industrial country in the world, at around $10,500. Vermont is the fourth highest in the United States. So that means we're the fourth highest in the world at around $10,100 in 2014.
Why do you think that is?
We have one of the most aggressive engagements in healthcare to get people covered, which is a good thing.
So as we see insurance premiums continue to rise, and they rise at rates much higher than the rate of inflation.
Yeah.
As they continue to raise, you look at it, and a lot of it has to do with the number of people that are on Medicare.
Neither Medicare nor Medicaid cover their cost, so that all gets cost shifted onto commercial
The insurance
ratepayers.
companies.
That's right.
Yeah.
Well, and it's not just by extension that you're cost shifting to the payers. The payers have passed that cost shift on to patients through high deductible plans. And so many patients have insurance that they can't afford to use. They can't afford their out-of-pocket $5,000 deductible, $2,000 deductible. And I would say, just to answer that question, I think you mentioned about why, the United States being at $10,000 and Germany being at $5,000. We have a capitalistic healthcare program, and we've done nothing to mitigate profits in those sectors. And so, the big one that comes to mind is pharmaceutical. We subsidize for the entire world, all the R&D, and Americans pay for it. Those are the things that even for a state, any state, we can't control those. Even Medicare, which is the single largest payer consumer of pharmaceuticals, can't negotiate pricing with pharmaceutical companies.
So how do we change it? I mean, that's not for you, but that's for legislators and senators to work on it. But it's been something, as long as I've been involved in media, that we've heard that question asked over and over and over again.
In terms of the cost shift, I think there are two elements to that. One is just to level the playing field in a way that hospitals are treated similarly, and that then takes you to the payer mix. I don't think it would be that hard before even you put another extra dollar into Medicaid, that hard to come up with a formula that equalizes the playing field across at least the 14 hospitals in Vermont. Whereas if you have a weak payer mix, you might get 110% of the procedure that the state says they'll pay. And if you have a strong payer mix, you might get 85 or 90% of so that the money kind of moves fairly across the system.
These are all numbers, and
Right.
and there's real people behind the numbers,
They are.
and that's the point. Is you talk about payer mix and who's coming into the hospital. Is it somebody on Medicaid, or is it somebody that's paying a premium to a private insurance company? And as a CFO, as I refer to it today, we have the regulated and the regulator. It's
Right.
almost like a wrestling match.
Nice to meet you.
In this corner, the regulator and the regulated. You can't. There's no way. It's demographics, the area that you're in, the mix of customers or patients that you have.
But it's also the difference of being a tertiary hospital as opposed to a community hospital. But for us, we were one of the founding members of the ACO. We went all in. We trusted the vision and the timeline to scalability. And had we continued the expansion of membership under the ACO, I think our financial situation would have looked very differently. But what happened is we made all the investments and we ended up with 2 flat years of attributed lives. And we reduced utilization to the tune of about $6 million in our revenue that declined because we were doing more care coordination. We were actually bending the curve on health. Because of all that good work, we also hurt ourselves in terms of utilization because we're still fee-for-service for 70% of our business. And so my question is, if we created $6 million of savings through decreased utilization, where did that go? And it went either to the insurance company or to UVM or to a self-insured employer.
And do you feel like you did all the work and you didn't get rewarded?
Yet.
Yes, yet.
Yeah.
Correct. That's an important distinction. And I don't necessarily see that as anyone's fault because the model is set on, it's a coalition of the willing. It's not mandated. We don't want to go backwards in making our community healthier. But by the same token, can we continue to lose $6 million in revenue every year because capitation hasn't caught up?
What happens to these hospitals that do that? They lose continually. If you owned a business,
right,
you're out of business. I mean, how long can you go like that? How do you make that up? How do you make those losses up?
Robin's right. I mean, you have this tension that is driven by the fact that we are one of the most expensive states in the world. You know, we spend a lot of money. It's not like we're at the bottom or at the middle. We are at the top. And the reform model, the all-payer model via OneCare, basically has two missions. One is to lower the cost of care. Northwestern is a leader in that regard, hands down. I mean, Robin is right. They started Rise Vermont, and the other is changing from a fixed prospective, a fee-for-service basis to a fixed prospective basis. And I think the simple analogy there is, right now we have a system that pays people for volume. The more procedures you do, the more revenue you get. And that's like a homeowner signing a contract with a contractor that says an hourly rate and materials. So it can, all the risk is on the homeowner. Whereas now, with prospect of payment, the risk gets shared among both payers and providers. And the other part of it are investments in population health.
Where we are in that, and this is the discussion I think the state, the Green Mountain Care Board has to have, as well as within the ACO. When are we going to start putting teeth to the model where it's not a coalition of the willing? And that if we've got 14 hospitals across the state and not everyone is advancing tactics that prove to decrease cost and utilization, then we're not going to be successful, because we can't even the playing field otherwise. Because a hospital like NMC, if we go another year and don't have any more attributed lives or don't receive a bigger slice of the pie, we cannot cover that shortfall of revenue because of the loss of utilization.
This is my favorite part of the series. We give our guests a magic wand. They can wave it. Robin, you want to go first? Wave the wand.
I am here for healthcare reform. I know our reimbursement system is broken. Our incentives and profits in healthcare are not aligned. And it would be for continued robust discussion like this in community and state partnerships to try and invoke change. But it's not going to be easy, and we're trying to figure it out.
I would resolve the cost shift and payer mix issue, because that then will kind of push more of the money out to the community hospitals, which are struggling. They have negative operating margins, and it will and it's important, I think, in Vermont, which is small and people like their institutions close to them. You know, if more hospitals go under because the cost shift and payer mix is pushing them under, that is a public policy that could be changed, and it should be changed.
I want to thank you both for being my guest today. Robin, pleasure to meet you. And Tom, good to see you again. Tom Pelham from the Green Mountain Care Board. I'm going to do a wheelie on this ad. And of course, CFO of Northwestern Medical Center, and thanks to Northwestern Medical Center for hosting us and allowing us to use their office here today. Thank you both for being with me today. And I want to remind you can see more episodes of Travels with Charlie on Facebook and YouTube, Travels with Charlie. And I'll see you in my travels.
If you be so kind and share what's on your mind, it's time well spent talking president.
What the heck do they all put the tie
We
in?
may not agree, let your thoughts run free. You can have your turn if you feel the burn.